Perfect. So welcome to everyone. We are so pleased to have our first webinar with all of you who are doing direct work with the patients and clients in this initiative. This is Jane Fox. I am one of the investigators on this project. With me is Mariana Sorengo, who is our project director, and we would all shrivel up without her. She keeps us going and moving here. What I want to do first is, I know that everyone is hopefully seeing what's on the screen, so please make sure that the volume icon that you have at the top of your screen, it looks like a little speaker, is gray to mute your actual computer speakers so that you don't have interference. If you're hearing me, you've actually called in, which is great. You've done the right thing. All of the lines are currently muted. If you have a question, feel free to type in your question in the chat function, or you can also raise your hand. Once we identify you or bring up your question, you can unmute your line by pushing *6 on your phone. And you can also then remute your phone by dialing *6. We really want to keep the lines as clear as possible, so if you can remember to mute and unmute appropriately, that would be great. So for us and for everyone else, we want to do a quick roll call by site to see who is on the line. This will help us to identify you and start getting to know you by name. And then it will also help the other folks on the webinar know who is also on the line. So what I'm going to do is I'll call the site, and I'm going to ask you to use the chat function and type in the names of who is sitting there with you, if you're sitting alone, just yourself, so that we know who's participating. So who do we have on from AIDS Arms? Great. Sharon, welcome. And next would be Comwell. Who do we have from our North Carolina colleagues? Oh, hi, Jean. Thank you. And next is Family Health Centers in San Diego. Anyone on from Family Health Centers? A little early for those West Coast folks. They're hopefully they'll be coming on shortly. However, I know that we have someone on from Harris Health. Who's on from Harris? Nelson. Thank you, Nelson. And our other West Coast colleagues I know are also on the phone from Multnomah. Krista, yes. Welcome. Thank you, Krista. Is anyone else with you? Perfect. It is still early there, you're right. So how about Pasadena? Anyone on from Pasadena? Erica? Hi, thank you.
Ed Cockrell.
Precious Jackson. Jennifer Mejia.
Wow, you're all on. Thank you.
Yes.
Nice and early.
Yeah.
And here's Adam from Multnomah. Great, thank you. How about my colleagues at the San Francisco Department of Health? Is anyone on from there? No, no Jason yet. Hopefully he will come on. How about University of Florida? Nope, not yet. And let's see, and Yale University. Who's on from Yale? Okay. Well, again, thank you all for joining us. Just to quickly let you know the plan, we are hoping to do this on a quarterly basis. So we will do a topic that you have chosen, whether or someone has chosen for you. Hopefully you have chosen. And we will do a 90-minute webinar every quarter to give you guys some professional development and education. And then on the in-between months, we would like to use this time to do some case conferencing and some discussion about how it's going working with the clients. And so we hope to speak with you every month. This serves a couple purposes. One, for us to learn about implementation challenges, successes, how things are going. It also helps you to build a community amongst yourselves. So certainly we'll do some talking, but we really would like for you to talk between and amongst yourselves as we move down the calendar and get to know each other better. So without further ado, I'm going to pass this on to Barbara Kochi, who is one of our colleagues at Boston Healthcare for the Homeless, and she is going to introduce our speaker for this webinar. Barbara?
Thanks, Jane. So I have the pleasure of introducing my coworker, Sharon Morrison, who is a nurse who's worked with us since 1997, and currently she's working at the New England Center for Veterans. And also during that time, she has worked for the National Healthcare for the Homeless Council doing trainings, and this is one of the topics that she did trainings on. And she worked for them from 2004 to 2008. So motivational interviewing is one of those topics that she's quite adept at, and I thought that she would be a great person to kick off our webinar series. So welcome, Sharon.
Thank you very much, Barbara. I'm going to assume that everyone can hear me, and if that's not the case, I'm assuming that someone will chime in quickly and type that they say they can't hear, and then we'll start from there to try to figure things out. But otherwise, I'm hoping that all of you are looking at a slide that says dedicated to all of you who are weary of essentially trying to advise or coerce or sweet talk or bribe or manipulate somebody into making a change that they may not be willing to not yet make. So that's my dedication to the process that we're about to embark on together. Doing these webinars are always a little bit awkward because it's sort of me speaking and there's no sort of response coming back in live time. So I apologize for that from the beginning. You know, if we were doing a training, it would be exactly the opposite of this, in fact, because what we would want to do is to get a lot of your feedback. So that being said, I'm going to sort of walk through these slides, and I'm just going to be talking at you through all of this, trying to get you to just get a little bit of a taste or a little bit of a flavor about motivational interviewing and how we all might be able to use it in the work that we're doing with clients. And then we'll open it up for questions that people may have as well. If there's something that I happen to be saying that does not make any sense during the time, you can certainly feel free to type in your question or your shout to me that it's not making sense. I'm going to try to pay attention to that as well on my screen, and we'll try to address it in real time if it's a possibility for me to do that. But otherwise, do not worry, because we will have time in the end for everybody to be able to ask questions as well. So let's get started. So I always like to start sort of with the actual by-the-book definition of what motivational interviewing is. And I want to break it down just a little bit, if you'll indulge me for just a minute, because I think that this definition of what it is kind of actually important. And the first piece of that, of course, is that it's client-centered. And when we say that it's client-centered, what we're really trying to say is that it's not provider-centered. It's not program-centered. It's meeting the person where they are, not where you think they should be. It's letting go of our own egos and our predetermined ideas of what we want the outcome of the exchange to be. We invite the person to come as they are. And we want to focus our interactions with that person on their interest, what's important to them at the moment. Because oftentimes when we're working with clients, we've got an agenda for what we want to get done, and they come with something else that's far more pressing. And if we don't address those pressing needs in the moment, we have essentially given them the message that we're not actually interested in what's going on for them. And that breaks the sort of beginning of where we're trying to build trust with people. So we want to really keep our focus on what the client needs and not what we think they should need at that moment. And then, of course, we say that it's a directed method. It's a goal-oriented method, and it's directive, but it's consciously directive. We're working, what we want to try to be doing is to working toward helping people to identify what their ambivalence is, what their confusion is about to change, and then moving them in a direction. And I know that that may have sound completely contradictory to what I've just said, but in fact, I'm hoping that as we go through these slides, this will become more evident about how, as providers, we're not playing a passive role in this process, but we're actually actively engaged in the process by listening to our clients, by taking the information that they give us, and then consciously moving them and directing them toward the conversation that will get them to think about sort of change and what might not work for them. And then, of course, we call it a method. So it's a communication method, actually, is what I want to say. A lot of times when people think about motivational interviewing, they think that it's a set of techniques that we're going to use, but it is not. It's not a bag of tricks at all. It's not something that we do to people, but actually it's a fundamental sort of way about thinking about how we are with people, how we sit with people, and how it's a facilitative approach to communicating with a client so that we're evoking sort of their natural sort of desire to want it to change. And then, of course, we say that it's we call it for enhancing intrinsic motivation, which means that it's a way to enhance the internal motivation of the person that they have toward a change. And again, as I just said, we're going to look at sort of helping people to explore and resolve their ambivalence. We're going to talk a lot more about ambivalence much later on in this process. Here's the simplest definition of it, and after all of that wordy stuff, this is what I like to say. It's really about helping people talk themselves into change. That's what we're going to do. We're going to help people to sort of look at what their needs are, what has worked in the past, what has not worked in the past, and then what's it going to require for them to be able to make a change. And I really love this because I think that this is really about sort of the spirit of motivational interviewing, and that it's really a transparent sort of process that we work with people. I try to tell the clients that I work with that really they are the experts on them. I'm not the expert, and that my only role is to try to help them to clarify what's important in their life, to identify anything that might be getting in the way of those things that they want to have for their lives. And furthermore, I sort of get very specific about this process, and I say that what I'm going to do when I'm talking to you is sort of listen to you and then to repeat back, and then we're going to try to make sure that I'm understanding what you're saying and then try to move forward from that. Because really the person's feedback that they give you along the way will help you to tweak what your ideas are and to tweak your sort of thoughts on how change can happen. So let's talk for just a few seconds about why we would even use motivational interviewing. Why use it? Well, it's an evidence-based practice. And we know that it has proven success and that this proven success has actually been proven through research methodology, and that it's produced consistently positive patterns of results. And so it's one of the reasons that we turn to motivational interviewing as a way to be with our clients, and that it really works with a wide range of professional disciplines. So whether you're a healthcare practitioner, whether you're a social work practitioner, whether you're a case manager, whether you're an outreach worker, all of those things, all of those professional disciplines can work together to be able to use this, because it's really about engaging people in conversation in a way that hears them, that listens to them, and that actually builds trust between you and the person. And what I like about it also is that it actually counters the myths of the unmotivated person. It's really an unfortunate circumstance when we meet someone who doesn't do what we expect that they're supposed to do, and then we blame that person for not doing that, rather than trying to find a way to find out, what they want and what can be helpful, and to work from that particular point of view. So here are the three things that I like to talk about when we talk about the spirit of motivational interviewing, that it's collaborative. I think we've talked about that for a few minutes earlier, that it's a partnership, and that it honors the client's expertise, and that it's evocative. We're really sort of presuming that everything that the client needs is probably within them. And what our job is to draw that out for them, to help them to sort of clarify for themselves what it is that they want to move toward, and what has not worked and what has worked, and then find a way to put the supports in place in order to get that change to be able to happen for them. And then again, it's empowering, that it affirms the client's right and also their capacity for self-direction, to make choices for themselves, even if those choices are not necessarily what we would envision them to be as in their best interest at the moment. And here are the 4 guiding principles. You'll learn as you move on with your learning with motivational interviewing is that it is filled with all sorts of acronyms to try to get us to remember things. So here's the 4 guiding principles that we talk about. We talked about this as being the rule. Excuse me, I'm going to take a sip of tea. So it's resisting the writing reflex. What we call the writing reflex, to want to move into some sort of a helping profession, that writing reflex is when we see something that is wrong, we want to make it right. And we have to resist that, in fact, in motivational interviewing, because, in fact, that can lead us down the path of trying to direct somebody in a way that may not be necessarily helpful for them. And then we try to understand the patient's motivations. We've talked about that earlier, listening to the patient and empowering the patient. And I do want to say, just as a sidebar here, that you will hear me say many times through here about using the word patient, and that's just because I'm a nurse and so I work from that word, but understand that, of course, the client can be used interchangeably there. So let's move to the next slide. So why do people change? Well, we know that the client's motivation is, in fact, important for change. We know that it is the motivation to change. It's the key to being able to change, whatever their motivation is for it. But as well, we also know that it can be greatly influenced by our reaction, by how we react and how we interact with the client. So I don't want to say that it's only from the client's perspective. So let's talk about some critical components for motivation. Well, these are going to sound very familiar to you because we say them all the time, that the person has to be ready, that the person has to be willing, and of course that the person has to be able. So ready, of course, means that it's a priority for them. To what extent does the person want or desire or have the will to change? Also, that they actually see a degree of discrepancy between sort of what the current behavior is and one that they may value for their future. So, self-regulation theory says that we're all sort of self-monitoring, and that as long as present reality is within our desired sort of limits, as long as it fits with, well, I don't feel too bad about something, then no change is going to ever actually happen. But when we get out of our own self-monitoring sort of range of what we feel is comfortable for us, then in fact our desire to change will kick in. And it sort of works sort of like a thermostat, if you might think about it in that way. And that when a lack of discrepancy actually exists in the process, what we try to do using motivational interviewing is to develop that discrepancy. So if your client is in a place where they actually don't sort of see any need to change, they don't see any problem that they're having with their current behavior, that's the kind of place where we, as the provider, can sort of be listening for things that they're talking about, listening for those discrepancies, and actually help to point those out. And I will show you much further on a little bit sort of some ways that we can skillfully do that. But it is our job, in fact, to sort of point out that, they may be saying this, but on the other hand, this is also happening. So we'll talk later on about sort of those discrepancies and how to hopefully be able to point those out. And then, of course, that the person has to be able to change. They may feel like it's important to change. They may want to be able to change, but they also have to be able to see that they have an ability to change. And this is really a place where we as providers, where we as someone that the person may trust, can help to build someone's confidence in their being able to do that. So often if a person is sort of not comfortable, if they're not comfortable with where they are, we can sort of help be able to sort of point some of those things out. Okay, so here's a good example of that is that, maybe the person is wanting to work with smoking, let's say for an example, and they may tell you that quitting smoking is something that's important to me, but it's not the most important thing to me right now, because right now I'm really stressed, and right now I have to figure out a way to work with my stress, and smoking helps alleviate that. Well, if we go down a path where we're just talking about quitting smoking with them at this particular juncture, what we're going to do is sort of cut off the trust that we have for them in that moment, and so we really have to sort of listen to that and to try to figure out how to move them from that place. I love this sort of slide because, we talk about how education is really not enough. And for so many of us, as we work in healthcare settings of any way, we sort of think that if people have enough information, then of course they'll just want to change, and they will in fact do that change. But we know that knowledge-based education it's important, but it's not enough. So if we go back to the example of smoking, for example, there's probably not a person that is alive who has not encountered at some point information that has told them about sort of the perils of smoking. And yet having that piece of information, understanding sort of what smoking does long-term for their health is not sufficient, in fact, for many people to be able to stop smoking. And so if we think about sort of information not being enough, then what are the things that we have to pull into that factor? And those things are, in fact, sort of understanding for the client sort of what are the emotional and behavioral issues that surround their smoking. Why are they smoking? When are they more likely to smoke? What are the things that they use smoking to help with? And then addressing those issues in order to be able to move to a place where they might be able to think about stopping smoking. And then if we just look at motivation in and of itself, we know that motivation is affected by both external and internal factors, that it's multi-dimensional, and that it fluctuates. And that's really a place where we spend a lot of time working with motivational interviewing, because it allows you to stay involved or engaged with the client in a way that doesn't recognize that the person makes a choice to change, and then they change, and then they stay changed for the rest of their lives. If that were the case, then all of the diet things or exercise things that you see every January on the TV and in the news would be put out of business. So we know that that changing is a fluctuating phenomenon, that it's not static, and that oftentimes our ability to change and our ability to stay engaged in behavior that, or things that can move us toward better health, is actually influenced by the relationship of the people around us. So some of the communication skills that we're going to use when we move into sort of using motivational interviewing is asking and listening and informing. You'll see in a few moments how those sort of move in and out of the way that we involve ourselves or interact with the clients that we're serving. So here's your next acronym, and that is OARS. And OARS is sort of the basic tools, if you would, that we use when we're sitting with someone in a motivational interviewing sort of consciousness about how we're working with them. So OARS basically stands for open questions, affirmations, reflective listening, and summaries. And we're going to go through all of these individually to sort of talk about what they mean and how to use them. So it's not a series, again, of techniques, if you would, but it's rather a way that we think about how we are when we're sitting with our patients. So OARS, I think, is my favorite one of all of them. And OARS means open questions. And oftentimes when we think about open questions versus closed questions, we think about sort of simply just yes and no questions. But OARS is but open questions are so much more than that. And what I love about open questions is that it invites the person to tell you their story. And it really focuses on seeking to understand sort of the context of their story, as opposed to the specifics or sort of the facts of their story. So the facts are not really what we're thinking about. It's really sort of about the context of their story. I can tell you a quick question yesterday that I did a health assessment on a veteran who arrived at the shelter where I work yesterday, and he came in, and in the middle of the health assessment, while we were starting to talk about health issues, he told me that he was originally from New Orleans. And in the context of the story, he talked about how he had been in New Orleans during Hurricane Katrina, and that he had sat on the roof of his house for 3 days waiting for someone to save him. And in the moment of his telling that story, he started to become tearful. And I realized that no matter anything else that we needed to accomplish in the time that we had together was going to need to be put on hold, because this many years later, as he started to tell the story, it was clear that it was still very present and very upfront in his memory. And until we sort of talked about that grief, until we talked about that loss, until we talked about sort of all of those losses that happened as a result of that event that led him this many years later to this shelter, we weren't going to be able to move forward. So I just say that as an example of a way that it's really important at all junctures when we're sitting with people to ask questions that allow them to tell you their story, and in doing so, it allows us to be able to better be able to understand and to craft with someone sort of what may be helpful for them along the way. So, and then this last little point here, I'll talk about later on, actually, about negating opening questions with closed questions. So that's one that's actually a very easy pitfall to fall into, and it's one that I actually fall into a great deal myself. I have to catch myself a lot with this, and that's sort of saying things like, "How you doing? You okay today?" So that's a good, easy example of how easy it is to sort of say and ask an open question and then close it right up, are you okay today? Because if the person isn't okay today, of course, I certainly haven't given them any sort of indication that I'm actually interested in how they're actually doing if I ask a question in that manner. So that's just a little teeny example of what we mean by that last bullet point. So open questions, seeking to understand, asking the person to tell you their story, and open questions is sort of the way that we begin setting the tone for how we're going to be with that person. It not only involves the questions, but it involves our body language. It involves our accessibility to the patient. It involves if we are acting like we're pressured, or we have to be somewhere else, or we're more distracted by something else that's going on. It's all of those kinds of things. It's how we show empathy to a person. That's what we mean by open questions. So when we get to affirmations, so affirmations are statements that recognize the individual's strengths, their personal qualities, and their values. Okay, they're reflected in the statements that we make, the gestures that we make, and the attitudes that we display to our clients. But they are ways that we recognize their strengths and acknowledge behaviors that lead in the direction of positive change, no matter how big or how small those changes may be. It's working collaboratively, and it's working to empower the client to sort of see all the things, the expertise, all of the strengths that they bring to the particular issue that they're trying to work with, that may help them to find the strength that they need to be able to make change. Affirmations in all forms work to build confidence in one's ability to change. And this is very, very important, is that they have to be genuine. They have to be congruent. They have to be absolutely heartfelt. And they're not the same as praise. So here are some ways that we can make affirmations that might be helpful. When we say things such as, I appreciate that you're willing to meet with me today to have this discussion. Or, you know, you clearly are a very resourceful person. The things that you've told me here today have shown me that you know how to get your needs met. And this can be very helpful, or this can be very productive for you in moving forward. Or that you really handled yourself well in a certain situation. Or another one that I oftentimes try to reflect with people is when I say things like, you know, if I had been in your shoes, I'm not sure that I would have had the strength or the fortitude to have managed in the way that you seem to have managed so well. So things that we tell the person that sort of show them that we're seeing their strength. You know, we can use questions for affirmations as well. So we can say things like, so what advice would you give me if I were talking to you, or if I were in your shoes? What advice would you give to me? And stuff like, have you had any thoughts about how you might improve the work that you wanted to do, and and ways that I might actually be able to help you. What sorts of things might I be able to do that would improve the situation so that you would feel more likely to be able to want to keep working with me here? So those are affirmations. We show people that we're interested in their strengths, and we're acknowledging what they bring as well. So reflective listening isn't really sort of the key to the work that we're doing. It's the primary skill, actually, and it's our pathway into engaging others into relationship. It's the pathway into building trust, and it's the pathway actually into fostering motivation to change. It's one of the skills that appears deceptively easy, but it actually takes a lot of hard work, and it's a lot of practice. And this is the place where if we were in a group together, actually working together, we would spend most of our time sort of working on this particular aspect of it. When we think about sort of how people talk or how people engage in conversation with each other, sort of we know that listening can break down in a couple of different areas. So it can break down when the speaker does not say what they actually mean. It can break down more often when the listener listens, but they didn't hear it correctly, what the speaker was actually trying to say. Or when the listener actually gives a different interpretation to what the words that the speaker has meant. And so reflective listening is used as a way to close that loop of communication to ensure that breakdown has not occurred. So the listener's voice turns down at the end of a reflective listening statement, and we'll talk about that in a few minutes, and that this may feel presumptive, and yet it actually leads to clarification and to a greater exploration, whereas questions can tend to interrupt the flow of the conversation that we're having. So there are some sort of standard phrases of reflective listening that you've probably heard a bazillion times in your life that you can always rely on if you're starting to use this and it's new to you. So things like, so you feel that, or it sounds like you're saying, or you're wondering if, those kinds of things. But the nice thing is that every reflection that we make back to a client opens up the possibility. It opens up the possibility that the speaker may tell you that, yep, you got it correct. It opens up the possibility that the speaker may tell you that, nope, you didn't get it correct, and so we want to add something to it or refine it. And so that's the nice thing about reflective listening, is that it allows us to sort of close that communication loop, to make sure that as the listener, we're hearing correctly what the speaker actually meant. And then the last of those letters in the acronym of ORS is summarizing. So let me see if I understand thus far. So summarizing, we say, is a very sort of specialized form of reflective listening. And it can be used throughout the conversation, not necessarily only in the end, but it's particularly helpful at transitional points. So say after the person has spoken to you about a particular topic, or has recounted a personal experience with you, or of course when the encounter is nearing the end. It helps us to ensure that that there's clear communication between the two people who are involved in the conversation, and it can also help provide the stepping stone that we want to take next towards change. So if we think about sort of the structure of some summaries, we want to begin with a statement that's indicating that you're making a summary. So, for example, just the one at the top, let me see if I understand so far. Here's what I've heard you say, or tell me if I've missed anything so far. And then we want to give specific attention to the change statements that the person might have made in the conversation. So statements that they have made that point toward their willingness to change, So there are four sort of types of change statements that sort of all overlap each other, and I'm going to just go over a couple of them with you. So one is a statement that there's actually a recognition of a problem. So the person recognizes that they have a problem that they want to work on. So that might sound like my drug use has gotten a little bit out of hand sometimes, or that they have a concern. I just know that if I don't stop this, something bad is going to happen to me. Or that they have the intent to change. I'm going to do something about it, but I'm just not sure what. Or I'm just not ready yet, but I'm going to do something about it soon. Or this is my favorite one, of course, and that is optimism. That I know I can get a handle on this problem if I just had some help. Or I know that I know how to do this. So those are all sorts of statements that tell us that the person is thinking about changing, they're moving toward changing, and that there might be some ambivalence. And we're going to talk in just a few minutes more, a little bit, much more in detail about ambivalence, because it is really the place where we want to start to sort of stir the pot, for lack of a better expression. So if the person is expressing ambivalence, it's useful to include both sides of that ambivalence in our summary statements. So say, for example, you can say, so on the one hand you're saying this, and yet on the other hand you're saying this. It can be useful to include places here where we can actually sort of pepper our conversation with clinical information that we may have, or research, or what we've seen historically with someone else who's been in the same shoes as that person. We can pepper our conversation with all of those kinds of things, but we have to be concise. And in the end, we want to end this conversation or end this process here with an invitation. So did I miss anything in my reflection? Did I miss anything in what I just said that I heard you say? And depending on the response that the client says to whatever you've summarized to them, it can naturally lead to the next planning steps, or it can naturally lead to taking concrete steps toward changing a goal. So commitment, we know, to change happens from two interacting elements. And one is the conviction that the person has the belief that it's important for them to change, and two, that they have the confidence in their ability to be able to change. And we've said that in a different way earlier on in sort of when we think about sort of ready, willing, and able. But I think it's worth repeating that the person really has to feel as if they have the confidence that they are actually able to change. And so let's just take a few seconds and sort of look at how change happens. I love this particular quote by Mark Twain that says that it happens, it has to be coaxed downstairs a step at a time, that it's not something that we just decide in a moment, okay, I'm going to do this, and then we toss it out the window, and then we say, okay, now we've changed, and then we stay changed for the rest of our lives. That's oftentimes how we would like to have happen, you know, particularly in the healthcare environment. It's so easy for us to see a healthcare provider, to go in with a problem, for them to say, okay, well, you have to take this medication, and you take this medication, and things will get better. And there's no sort of an accounting for, you know, are we able to get the medication? Are we able to pay for the medication? Are we able to take the medication, have access to the medication in the living environment that we live in? Are we able to manage the side effects that may happen with those that medication, any of the kinds of things that may get in the way of us simply just taking a medication. And unless we've sort of addressed all of those things in the conversation that we've had with a client, it's easy to sort of have them come back and not have taken the medication, and then, of course, to blame them for that. So, and we also know that when anybody is thinking about change, that there is a process of grieving and a process of loss between old behavior and new behavior. And so we really need to sort of explore that with the person. We need to ask them about sort of what it is that they might have to give up if they were to make this change, and what it is that they might see that they could benefit from if they were going to make the change. So again, we've talked about this in the past, that ambivalence is a normal part of the process of change, and that when people are resistant to change, it's not our place to try to talk them into changing. It's not a place where we try to force them to force them to see why it's important for them to make a change. We want to think of the client as being not in an adversarial role with them, but rather that they're our ally, that we want to sort of do a dance, if you would, with them, and that the need to change is really intrinsic. And so our role as it were in this particular case would be sort of like tending a garden, where we want to nurture it, fertilize it, sort of plant the seeds, help them to sort of find all of the things that might get in the way, the weeds that might get in the way, sort of help them to cultivate the things that they might need to cultivate in order to make the changes necessary. So we're going to talk for a few seconds about just eliciting change talk. And again, I gave you some examples earlier about change talk, but change talk is anything that the client says that favors them in the movement of changing. And the way that we elicit change talk is to go right back to that place where we talked about with ORS, and we start asking evocative questions. We ask for examples. All of these kinds of things are open questions. We ask for elaboration on the issue. And that we talk about sort of the extremes. We talk about sort of, one end versus the other end of the change. On one hand, you're saying that you're not ready to stop smoking, you don't want to stop smoking, and on the other hand, you're concerned about the price of cigarettes and how smoking costs so much money that you don't have any money to buy anything else that you want to buy. So we sort of query both extremes. And then we want to look backwards and forward in the person's life, sort of, what has not worked in the past, what has gotten in the way in the past, and then looking forward, and then exploring what the person's values are around the change. Here's just a few things. I love this. This is an old 1930s Fletcher Henderson tune that says, "My sweet tooth says I want to, but my wisdom says no." Or this one, which I love as well, that says, "I'm so miserable without you that it's almost like you're here." Let's talk for just a few seconds about ambivalence. I want to change, and yet I don't want to change. Again, this is in the place where most of us sit. It's the place where we have also the greatest propensity for moving forward, and it is the place where, as a provider, we have, in a sense, the most leeway to actually help someone move along the path. So it's a great place. It's an okay place to be. This place it is. And ambivalence, it's not a great place to stay. So ambivalence is closely related to the concept of conflict, which is central to many psychological theories, of course, and that conflict can happen in many ways. Choosing between two things that are attractive options, sort of the candy store problem, should I work on this or should I work on that? And sort of the avoidance way is another way that we have conflict. Choosing between two or more evils, if you would. Two things sort of caught between a rock and a hard place. Two things that have negative consequences. should I clean my bathroom or should I clean my bedroom first? And then, of course, there's the approach avoidance one. I can't live without you, and I can't live with you at the same time. Or sort of the double avoidance approach, which is that I'm torn between two alternatives, both of which I'm drawn to, and both of which are also causing me trouble. This is a little tool that I oftentimes work through with people. And I don't do this physically with people, but I sit with people and I work through this. And this is really a really great tool to use when someone is ambivalent or they're expressing ambivalence about change. And it is important when you're using this tool to sort of think about it. It has to go, this one does have to go in a linear fashion. So we want to first start by asking the person, so what are the benefits of not changing? What do you get out of drinking? What works for you? What is helping you? So you're drinking every day, and tell me what you like about it. What works for you? What's helping you? And then explore with the person sort of is it causing any problems? If they tell you that drinking is not causing them any problems, there's the place where you have sort of two options. If they've said anything to you in the past that has shown you that it has caused problems, this is the place where you get to say, well, on the one hand, you're saying it's not causing problems, but on the other hand, you're saying this. You can help to draw out their ambivalence there. But if the person has not given you any indication that they see their drinking as a problem, then it's probably such that they're not ready to start working about their drinking. And you might want to just stop in that place and not move any further and talk about something else that might be more helpful to sort of build rapport in the relationship. Remember that every encounter that we have, the ultimate goal is to not break the trust so that the person can come back. You don't have to get through all of this in one session. This is about the way that we are with people. It's not about sort of doing stuff in a strategic way so that we get all of these done in one session. But this is a chart, sort of a grid that I use that helps the person to sort of think about changing. And the idea is that you want to talk about the benefits and the cost of staying the same, and then you want to talk about sort of what the costs are of changing. What might you have to give up if you were to stop drinking? What would be hard for you if you were to stop drinking? What are the things that it's going to cost them? And explore that and really show respect for that, because that's the place where we allow the person to grieve the loss or the anticipated loss that they see about having to change. And then this is where it's really key, and that is that you want to end that conversation with them thinking about what are the benefits of their changing. And they don't have to come to a conclusion about the need to change. They only have to be left with the idea that they're thinking about what are the benefits of what the changing is, because that's the place that they will take home and that they will continue to reflect on. So when we use this grid, it's really sort of a place where I say that we're starting the conversation to gently get the person to be thinking proactively and to be sort of stirring the pot in a way. So here's what change might sound like. Here's what change might sound like if the person were to be thinking about changing. I can't figure out what to do about this, or I think I should get tested for this, but I'm afraid to get tested. It scares me to think about taking all of these medicines, but I know that if I don't, that my diabetes will remain out of control. I know I'd be better off if I stopped drinking, but I don't know how to do that yet. These are some of the things that we might hear somebody say that will indicate to us that they are thinking about changing. And again, when you hear these things, our job is not to be a cheerleader, not to sort of push for the why it is that yes, change is good, because the moment we do that, we push someone into a place where they're going to feel the need to defend what the status quo is. So if we sort of hear these things and we help them to just settle in their ambivalence and help them to sort of think about sort of what might be beneficial for change, but we're not there sort of saying, yes, I know you can do this. Yes, this would be a good idea if you do this. We're in a better situation to get them to actually make the first step toward changing, because really what we're trying to do is to help them to just explore their ambivalence until they come up with what might be able to be helpful. And that doesn't mean that we don't get to make suggestions, because of course, as providers, that is a part of what we want to be able to help people do. But of course, if we're going to give advice, or if we're going to provide sort of ideas about some things that they might find helpful, or what we have seen other people do that might be helpful, we need to always begin that process by asking if they mind if we offer advice. I'll talk about this a little bit in a few minutes. I want to go back and just talk a little bit about resistance, because oftentimes when someone is thinking about changing, they'll throw out some ideas, and then what we do is we sort of get on the bandwagon. Yes, it's a great idea. I'm so glad that you're thinking about doing that. And then what we see is that the person becomes resistant. Resistance is a natural part of the process of change as well. And really, we should take it as a signal that what we need to do is to change our strategy. Rather than push back, we need to change our strategy, because how we respond to resistance is directly related to how the person will become either more defensive or much more willing to actually think about and get re-engaged in the process of change. So here's what resistance looks like. The person is already looking at their clock or looking out the door. They're arguing with us. They're refusing with us. And they're saying things like, yes, but. Here's my place where I love to talk about giving advice. I love this little cartoon. So do you mind if I give you some advice? Well, do you mind if I roll my eyes and sigh deeply and dismiss your advice as if it came from the village idiot? Well, I might mind. Well, then let me give you some advice. So really, this is a joking sort of way to say what we oftentimes do, which is to try to give advice before the person is actually willing to hear any advice or even welcome advice from us. So we need to be very cautious about giving advice without asking permission first. And if the person says that no, we're not interested in your advice, or no, I don't really want to know what's available to me to stop smoking or drinking yet, then we absolutely have to respect that and not go there yet. And we can say things like, you know, if at any point in the future you want to talk about this again, I will be here for you, and I hope that you will talk with me about it again. So as we're sort of moving toward the close of this, before we open it up for questions, I want to talk a little bit about sort of building confidence with people. Confidence is key to, it's critical to anybody's ability to be able to change. They have to feel like they're able to be able to do so. And so the way that we as the provider can build confidence is by doing things like reviewing successes in the past. And we will know what successes have happened in their past because we will have listened early on in the conversation to the story rather than the specifics, rather to the feeling and to the sense and to the sentiment around it, and they will tell you what has worked in the past. So we're able to review that with them and help people to see that, in fact, the very thing that they need to succeed already lies within them. We can talk about sort of small steps that someone might be able to do, like even just one small step, which is, for example, cutting down. For the longest time at Healthcare for the Homeless, I did diabetes education with people, and they were always sort of profoundly surprised that I never asked anybody to give up desserts, because you know, asking somebody to give up desserts is just it's the first step toward telling people that the only way to manage their blood sugars is to do something that is going to feel completely like it's unmanageable for the rest of their lives. But we can ask people to try to do things like eat their dessert and take one forkful out of the dessert and put it in a paper towel and put it away, and then eat the rest of the dessert. And that may not feel big to you, but by gosh, it really is big, and it is a step in the right direction. And we can move people toward these very initial first steps that can make people feel like they can manage the success of the change as well. So we can talk about sort of what are the barriers that they've identified that might be getting in their way. So, for example, somebody may tell you that, you know, part of their problems with being able to stop smoking is that they're in a treatment program that has 6 smoke breaks a day. And so they go out every single smoke break because that's their socialization time outside of the groups. And so we have to help people to sort of solve some of those barriers that might get in the way of being able to address change. And of course, providing strategies or resources or skills that may help. And then attending to that progress, and that when people make slips, as we know will happen, we don't use those slips as a way to make people feel like they've been a failure at something, but rather that we use those slips to sort of say, so what did we learn from this, and how can we do something differently the next time that might better ensure people being able to make changes. And then lastly, I actually just want to talk about bearing hope for people, because I believe that oftentimes the most important thing that we can do for people's lives is to bear witness to what their suffering is, even if we don't have the answer to the problems, even if we can't if we ourselves can't see where the next step can come from, that our job is really to bear witness to people and to give them the message that we are standing with them and that we believe that they can make these changes even when they believe they can't see that they're able to do so. Because we know that that many people, when they've made grand changes in their lives and you talk to them years later about what helped them along the way, they will tell you that people believed in them even when they did not believe in themselves. Oftentimes, people, particularly in substance abuse recovery, you will hear over and over and over again when people have had years of recovery under their belt tell you that their counselors or their doctors or their case manager believed in them and never said no to them, even when they came in time and time and time and again, having used. So I believe that part of what our job is in all of these encounters that we have with people is to bear hope for them when they don't know that they can hold up hope for themselves. And in doing so, we reflect back to them that we believe in change and that we believe in their ability to be able to do so. So I want to stop there and just say thank you. I know that there's a survey that we're going to ask you to do in a little bit, but I do want to give people an opportunity to ask questions if anybody has any questions, and I'll take it from there.
Sharon?
Yep.
Hi, it's Mariana. I know Ed had a question that he typed in the chat box. Can you give more examples of change talk? That was his question.
Okay, I'm actually not seeing the questions here. I'm not seeing the questions here. So Ed, so maybe you could just tell me. So Ed had some questions about change talk.
He would like some more examples.
Yes, let's go back. Can I go back to that slide?
Yep.
Yay. So change talk, of course. I think that some of the things that I said to you were change talks were things that indicated to us that the person was thinking about changing. And they're not necessarily things that say, you know, I'm ready to do that, but rather that I want to do that. So some of those things could be, I think I had given you some examples like, well, I know I need to change, those kinds of things, right?
Yes.
Okay. So, let me think of if I can think of some other examples of what change might sound like. So I know I need to change, but here's a good example of something that somebody said to me. You know, I want to get let's say if you're thinking about housing. I know I need to get housing, and my counselor is telling me that if I want to get housing, I need to be involved in mental health treatment. And I don't want to do that because I don't think I need to do that. I don't think that there's a problem. I'm not sure what it is. And yet I know that I need to do that or else I can't get housing. So there's a perfect place that we might want to explore. First of all, if the person is feeling pressured to change, because if the only motivation to change is that, you know, they need to get housing, well, that's not going to be sustainable. The person has to actually sort of see that. So one of the things that you might do in that particular situation is to sort of say, I wonder what, if you were in your counselor's position, what are the things that you might think that they are seeing that tell them that that they want you to change? So you take it off of yourself, you take it off of the client themselves, you sort of put them in charge. You put them in charge of sort of seeing it from the other person's perspective. And they might be able to tell you some of the things that they have done or the behaviors that might be disconcerting for their counselor. And then from there, you can take it to a place where you say, so, you know, so you don't feel like you actually want to get involved in mental health counseling. You don't feel a real need for it. And yet, at the same time, you can also see that your counselor has seen this particular behavior. So all you're really trying to do there is sort of show the discrepancy, if you would, show sort of the difference of the weight between those two things. Like, you know, on the one hand you're saying this, on the other hand you're saying that. So that's one of the ways that you might be able to help somebody move through that place where they get stuck. But change is really sort of anything, change talk is really sort of anything that the person says that indicates to you that they're thinking. Not even that they're ready to act yet, but that they're thinking. You know, if they say to you that something has been problematic, if they say to you that something is getting in the way of their being able to move forward. I had a guy that I worked with many years ago when I was doing this diabetes teaching, where I was sort of walking through that four-piece grid that I had just shown you earlier. And one of the things that he had pointed out to me was that he didn't feel like his drinking was getting in his way. He didn't feel like his drinking was a problem. And yet we knew his blood sugars were elevated all the time, and we knew his blood sugars were in direct correlation to the amount of alcohol that he was drinking. But he didn't feel like he was drinking so much that it was problematic for him. Later on in the conversation, he talked about his family, and in the context of talking about his family, he said that, you know, when the winter came, he was a little worried because he oftentimes slept outside, and that his family was nearby, and that his sister would allow him to sleep on her couch if he wasn't drinking. But she did not allow him to come into the house when he was drinking because of her children. And so we were able to sort of help him to sort of look at that place between his desire to want to be warm and his desire to want to sleep inside during the winter time where it was warm, his desire to want to be close to his family because he had talked about that in the context of his family, and yet the one barrier that he had between his ability to be able to do that was the fact that he was drinking. So he was able to sort of see the two differences between that and then work toward that change.
Thanks, Sharon.
Sure.
So are there any other questions? At this point, you can raise your hand by clicking the little person raising their hand icon, or you can type it into chat for Sharon at this point. So Sharon, can you maybe give some folks some pointers if in fact they're new to using motivational interviewing and want to try this out? How can they ease themselves into this? Or is there
That is a great question. That's a really great question. So I always suggest that if you want to start, a good safe place to start is at home. So I'm assuming that everybody here is in relationship with somebody in their lives, and if you're in relationship with somebody in your life that you actually live in a house with, that's a great place to start. It's a great place to start because you can practice in a place where you don't have to feel like you're going to do anything that you may not feel comfortable doing. And the great way to start is by asking the person that you're in relationship with an open question about their life. You can even start with just something as simple as, how was your day today? That's an easy and open question. And then allow them to tell you about it. And in the process of telling you about it, practice listening for the content, practice listening for the feeling, practice listening for the sentiment around it. Sometimes I think if you practice these kinds of skills outside of the place where you feel like you have to do something, to move something, to change something, to fix something, it's a lot less pressure on you, and you can start there. So I always say start with somebody that you're in relationship with and start by asking open questions. You might be surprised to find how just asking some simple questions can actually open up bigger conversations. And then if you sort of look through these, slides here, you can sort of get some ideas about how to move from asking open questions to the other pieces of it, the affirmation of it. Really, I think if you focus your practice on open questions, asking open questions, and actually reflectively listening to the sentiment of the dialogue as opposed to the concrete sort of aspects of the dialogue, you will move yourself along this practice very, very quickly, because it's really the place that is key to all of this conversation that we have.
Great, thanks, Sharon. So we have a chat message from Jean. Ideally, we as people would always like to choose between good and bad. However, most of the time for the clients we serve, the choice is between bad and worse. Any tips on how to relate to this? So harm reduction-y to me.
Yeah, and I would actually, yes, I would say that, I would worry about who gets to make that choice of what's bad or worse. That feels very much like, the person may not see them as bad or worse. And until that, whatever that choices are, becomes a problem for them, then we can't do anything toward moving. Because the person has to have the sense for themselves that there is a reason why change needs to happen. And so as soon as we get into a place where we've made a call that whatever this is not good, then we've already set ourselves up into sort of a resistance place with them. And so our place is really not to sort of make that call. Our place is to sort of explore for them, what does that mean? What is the significance of whatever that behavior is? We may know in our hearts it's bad. I mean, we know that some of these things are not good in terms of helping people with their health, but we have got to sort of resist that sense to want to go there and actually explore with them what it means for them.
And what if the client actually recognizes that choice A is bad and choice B is worse? How do you then think about with them how to make the change or make a choice, or do you then attempt to find a choice C?
No, what I would do is in that particular, if a person is telling me that I know that I'm doing this and it's terrible and I'm doing that and it's terrible also and none of this is serving me, I would say, so then tell me how you would, when you think of it in the best possible solution, in the best of a world, what would it look like for you to be different? What would look different for you? What would you like to have happen that could be different from what you've just described to me? And let them talk to you about what it is that they want. And then you use those two different sides of that coin to bring together, how do we reconcile that? How do we reconcile the place where you would like to be in comparison to the thing that we know is happening right now that's not working for you?
Got it. Thank you.
Sure.
Any other questions for Sharon at this point? Comments? Sharon, any closing words? Well, before you say something, so next month we are not able to host a call, but we will host a call with all of you, a conference call in November. We will be bringing Sharon back. So for those of you who are interested in applying some of these techniques, please do so, and we will talk more on an open venue come November about how did it work, successes, challenges, what can we do to help, resources you may need along the way, and we'll continue this conversation, but more in a conversation sort of way. And then before I hand it back over to Sharon to give some final thoughts, there is a survey on the last slide that we would really like for you to complete. That helps us to know if we are meeting your needs, as well as if you have any resources or other things that we can help with. We would love for you to quickly go do that webinar survey. So Sharon, any closing remarks, thoughts?
Well, I want to thank you again for your commitment to helping people to move along pathways of change, and for your bravery and your willingness to try to do things in a way that will may seem awkward in the beginning, but I feel confident that with a little bit of practice, this can become second nature to you in the way that you have conversations with people. And I guess I would say that if we're going to talk again in a couple of months or in a few months, I would ask people to actually try, just if they do nothing else, to just try asking open questions with people and sort of, and then pay attention to how that feels for them in terms of asking open questions, and what the response is, what happens to them in the process of doing that, and maybe that can be the place where we start when, our conversation again when we come back together.
Beautiful, beautiful. Thank you so much, Sharon. Thank you, everyone, for your time. And Mariana and I and the rest of the MedHeart team, we are always available to you through our website, or I think you at least have Mariana's email from us emailing you. Please feel free to contact us with anything we can do to help, and please complete the webinar survey. We'll be in contact with you about the call in November. Thanks,
all right,
everyone.
thank you. Bye-bye.
Bye-bye.